The main thing that I look at on a case like this and realize is that by having a deep bite, he's hitting heavier on those anterior teeth, and he has a dual plane bite. So his lower molars sit further down, they're more apical, and then his canines and incisors sit higher, and those are getting smashed. And so the chipping, damage, and wear that's happening to these teeth is fairly significant. And it's also on his upper teeth. And even when you check and the trays are fitting, it'll fit. And you'll say, look, there's a gap. It's backing up. It's working. But the reality is it's not, because aligners are just a force system. So if you're pushing somewhere, where do you push to make that movement happen? And the location of where you would push right now is you'd push down on this attachment right here, and you'd push up on this palatal cusp. So this patient presents in our office, and this is an oldie, but a goodie, 2019. Total treatment time in the end, he's going to be in treatment for about 2 years. And what you're going to see in his case is that the first chief complaint he's coming in with is crooked teeth. Now, I always like to show perfect clinical photos, but I also sometimes want to show you the reality of what these photos actually look like when they're not the best. Right at this point in time, this is when we first started using some iPhones in the practice. And so you can see the quality isn't great. We use an SLR camera in almost all circumstances, but sometimes when we're training staff, we'll use an iPhone until they get their technique right for location of photos. And then once they have the right location and the proper views, then we graduate them back up to an SLR. So just like in our practice, the reality is that it's not always perfect. So don't love the photos. You'll see in all the other ones, then we start using SLR cameras and everything looks much better. But this is the reality of the photo. So crowding on his front teeth. And the second complaint he has is that he's lost his lower first molars. And he'd like to do something about that space because he finds it hard to chew, which makes sense. The mesial cusps of his lower right second molar have tipped, and as the teeth tipped, those cusps relatively intrude. So he's no longer occluding on the anterior of that tooth. Another concern that he'd like to deal with, but at the end of treatment, will be his discoloration on a filling that was done on his front tooth. In addition to all of that, he has a deep bite, and we can see that there's chipping and wear on the teeth. Now, let's say he was coming into the practice and his main concern was not necessarily dealing with the crossbite or the tipped molars or anything else. The main thing that I look at on a case like this and realize is that by having a deep bite, he's hitting heavier on those anterior teeth, and he has a dual plane bite. So his lower molars sit further down, they're more apical, and then his canines and incisors sit higher, and those are getting smashed. And so the chipping, damage, and wear that's happening to these teeth is fairly significant. And it's also on his upper teeth. So it's not that putting these teeth into a better position will stop him from ever grinding his teeth or damaging his teeth. But the main difference is that he's not going to be hitting prematurely on those teeth alone. Instead, his occlusion is going to be balanced. So with all that being said, he agrees, yes, let's go ahead and do treatment. I'd really like to improve it for both functional purposes as well as for aesthetic purposes. So let's go ahead and take a look at ClinCheck number 1. So we submit our ClinCheck. And what do we get back? So you guys have, if you've watched me before, seen that I approach ClinChecks in a very consistent way every single time. And how I do that is I type in review-adult, and what you're going to see here is it's going to go ahead, and let me just zoom in first. As soon as I finish this word, it's going to actually pop in a set of protocol instructions for me to review. This is my checklist. And this checklist allows me to approach the case the exact same way every single time. Just like a pilot, before taking off, has a checklist of what they do every single time, this checklist is going to help me evaluate the case and determine if I'm happy with the basic setup, and then if I'm happy with the detailed aspect of it. And so the first line item that you're going to see here is I'm going to review the technician's comments. Now, hopefully this isn't too small for you guys. I know Zoom downscales the quality, but we're going to review the technician's comments. So on ClinCheck number 1, did the technician say anything of relevance? There was some trim teeth, the trim teeth removed. They gave me prescription cuts. There was optimized root control attachments, and some attachments were colliding with the opposite arch. So really, nothing of relevance. The next thing I always look at is, do I have some passive aligners at the end of treatment? So aligners that don't do anything. And so if you look at the bottom, these last four trays don't move the teeth. They're literally just there to hold the position while we get new aligners. So 4 passive aligners, yeah, we've got them. What's next? Was the bite set properly? So we can look and compare our clinical photos and see, was the bite set properly? I'm just going to tell you already, it is. Okay, so that's my basic things that I want to see on every single case. What's next? Well, was this case set up to finish in the position that I want? Now, in some cases, I don't want to finish in a class 1 occlusion. But in this case, we are looking to improve the position of the teeth in terms of class 1 in the anterior posterior. And so when we go ahead and we check now to see, well, what movements are happening? Are we opening up space for our implant and ending in a class 1? On the one side, you'll see that yes, there's some sequential distalization occurring, and this molar's moving. But what's going on here with the other side? It's actually showing closure of that space. Well, that's not actually what I want. I don't want to close that space because realistically speaking, when looking at this pan, this root is so distally inclined, it is going to be extremely challenging to swing this root 10 millimeters through space to get the roots lined up parallel with the lower premolars. Same thing on the other side. This is just a very, very challenging situation to do. It's not that it's impossible, but what will end up happening is that it's going to take 2.5 to 3 years for sure. Likely we'll want to use TADs. And the other thing is, if we don't use TADs, these teeth in the anterior will shift towards the patient's right. So essentially, if we go ahead and just go from here again, right now the midlines when he bites are pretty close to being on. You can't quite see the lower teeth back here, but the lower teeth are on. Now when he opens slightly, there is a deviation. But if you go ahead and close the extraction space in one section, then what's going to happen is the lower midline will shift this direction. Because the molars, yes, they will come forward, and the roots will come forward to some degree, but it's going to be pulling on these anterior teeth to pull them towards that space closure. So if we leave a space on the other side, we're leaving this space, but we're closing the other space, then there will be shifting of that midline. So we're going to treat this as an extraction of the wisdom tooth and distalization of that second molar. So this immediately tells me something super important, right? Just by going through my checklist, I realize that there's been a huge mix-up in terms of what the goals are, with that molar drifting forward and the root tipping through 10 millimeters of bone. And so what that tells me is I can go ahead and not even really pay attention to anything else on this ClinCheck. I would literally just go ahead and erase all of this other information for me to review, and I would just tell them, do not close the space of the lower first molar. Instead, distalize the lower second molar and virtually remove the lower right third molar without doing anything else. That's initially something that we'd want to do. So let's take a look at treatment plan number 2. And because treatment plan number 2 now is going to feature just that. That's what we're going to be asking them to do. Now, I did make other changes on treatment plan number 1. You can notice between here. Oh, let me get the right view. Between here and this is treatment plan number 2. So I am going to continue showing the other changes that I made in treatment plan number 1, even though realistically, if I was doing this now, I would just go ahead and redesign it immediately with that one change to happen. So that's the first thing, is that the teeth are not in the right spot. Okay, the next consideration is the curve of Spee. So we're starting off with a significant curve of Spee. And again, this doesn't have to be a super complicated case like you see here, You could be treating a more basic case, but if you see a significant curve of SPE, well, if you just go ahead and move these teeth so everything looks perfect at the end, and it's nice and even across like this would be here, you're not going to get as much as what you ask for. So you always want to ask for over treatment. So looking at our lower canines and incisors, you can see they sit lower down at the end of treatment because there's been over treatment. Now, I would argue that this canine tooth has been over treated too much. It's sitting lower even than our lower incisors, and so I'd rather a more progressive step. So I might go ahead and make a note here and say lower left 3 don't intrude as much. Right, just a note for myself. I can adjust this with the 3D controls afterwards. Okay, what's next on my list? Well, next on my list is the upper expansion. So are we expanding the upper arch? And should we be? When we look from our initial position, we have a narrow arch. Now, unfortunately, the photos, again, don't show the best. But if we look at the bone available here, in certain areas for sure, like this premolar where we're in crossbite right now. So if we look right here, you can see there's tissue there, there's bone there. You can palpate it. So because there is bone available for this tooth to move into, then I feel comfortable knowing for sure that we can absolutely expand in this first premolar region. Same thing when we look at this side on the patient's left, right? We actually can see and we could palpate and we could take a CBCT and we could see that there is bone available for us to move these teeth. So there's definitely some arch development that can occur. So when you look, then if we have some arch development and expansion, we can really see this by clicking on the superimposition tool. Then we either make the decision, are we happy with that expansion, or is it something we don't want to have? Now, in reality, with this ClinCheck, I might look at the position of this second molar, that the expansion that's happening here at the end, it looks like that tooth is sitting a little bit more lingual than the other teeth. So I maybe would consider actually expanding this tooth a little bit more. So I might just say here, increase expansion on the 2-7. And again, what I wish I could do on these ClinChecks so you guys could see is I really, really wish that I could actually make a modification to this treatment plan number 1 so you could see me take the 3D controls. But the only plan that you can actually modify here is if you want to do a modification for one of these like test plans, you can only do that modification on the most recent plan, right? Because this is just a test plan that I'm using. I've exported this as a test case, but I can click modify, but only the most recent ClinCheck. That's kind of annoying. Okay, so back to treatment plan number 1. So maybe increase the expansion slightly on that upper left second molar. Same thing, our upper 6s, do they have good contacts? Are they parallel with one another? Well, no, I don't really love this contact between these two teeth, so we could improve that slightly with a bit of rotation. No, I would just use the 3D controls for that again. I'll show you an example of what that would look like in just a minute. I'll jump on the final ClinCheck and just show you here, but rotate 2, 6, make a better contact. Well, these are just for me. These are all things I can change myself. Okay, let's go ahead and take a look at the smile arc. Now for this, let's jump to the patient's real photos again. Okay, any canting going on or major smile arc changes that are needed? Well, we do want to obviously expand the upper right first premolar. Other than that, there's nothing significant that's going to change with the smile arc. No major cants. So we can get rid of smile arc, get rid of cants. Okay, do we have any fragile tissues that we're really worried about with lots of expansion? These tissues aren't amazing, but there's very little expansion that's actually going to be occurring here. So I'm not too worried about the expansion on the lower. On the upper, same thing, not too worried. There's not a significant amount of crowding in this case. Okay, so we don't really need IPR for fragile tissues. And then Bolton analysis. So the Bolton will not give us the full analysis because he's missing his first molars. And then it tells us that we have a mandibular excess of 0.8 millimeters in the 3 to 3 region. So it's just saying between the canine to the canine that there's a little bit of extra tooth structure. Now, I'm actually slightly surprised that we don't see more of a Bolton here because his lateral incisor is pretty small. Normally, a rule of thumb would be if the lateral incisor on the upper is the same size as the lower lateral incisor, it generally means that there's a Bolton discrepancy, meaning that we either need to do some IPR on the lower or we need to make spaces on the upper for some restorative. Now, the thing is, though, that this patient is pretty class 2. Right? The Bolton analysis is telling us how well do the arches fit together if they're in the proper anterior-posterior position. Right? If there is a large overjet, like we're seeing here, then we're not really worried about going from this large overjet to suddenly hitting edge to edge. Realistically, it's just not going to happen. So because of that, we're okay with the fact that we don't really need to leave extra space for a Bolton discrepancy to make our lateral incisors bigger if we have a large overjet and if it's not one of his chief concerns. So since it's not a major concern to him that his laterals are a bit smaller, we don't need to go ahead and plan a bunch of IPR on the lower or leave spaces on the upper laterals for bite purposes. I hope that makes sense. But the reason why you do IPR on the lower arch is, in my opinion, either for fragile tissues or because there is a Bolton discrepancy. We're not doing IPR because we're trying to, I don't know, do a whole bunch of IPR on the upper teeth to move the teeth faster or anything like that, right? The goal for me with this case is to give him the best result possible. And if I don't need to do IPR on a ton of these teeth, just for the sake of trying to make it less crowded when realistically I can do all of this without doing a whole bunch of IPR, well, both from a patient comfort, a tooth health, I'm not worried about IPR, but we are removing tooth structure when doing it, as well as from a clinical efficiency standpoint. I'd prefer not doing IPR on this case if I don't need to. So those are my main two considerations. We need it for fragile tissues. Do we need it for the bite to occlude properly? Okay, so we don't really need it for the Bolton, even though the lateral on the upper compared to the lower incisors does look like it's small. Okay, I'm going to reduce that section. So staging. So now we're looking at some of the specific movements of the teeth. Are the teeth moving directly from where they need to be to where they're going to finish? Now, we'll look at the upper more to start with because the lower we're making those changes to. So what it's showing here is it's showing sequential distalization, right? Teeth backing up one tooth at a time, and then it's showing a delay, and then there's going to be expansion later on in that right side region. Now, some would make the argument that we should wait before doing that expansion so that we're not overtaxing the plastic. And I would be okay with that. I would also be okay saying, well, as long as we have the right attachments on this side to really lock the tray in, then we could go ahead and do some expansion while teeth in quad 2 is upper left, while those teeth are distalizing. I think both of those options are okay. So I am okay with this this staging, but I also would be fine if it was changed and some of the expansion started sooner. I think either of those is a valid option. But the main goal to see is, on any of these other teeth, round tripping means are they moving one direction and then moving back the exact opposite direction? Well, they're not. Everything's moving directly from start to finish. The next thing would be is, are any teeth extruding? This will come into play later about extrusion. So is anything extruding? No, not really. The anteriors are not. So we don't need to worry about the staging for the extrusion. The next one would be black triangles. Is there any concerns that we're going to get black triangles because of really triangular teeth? The ClinCheck can often be really good at showing us where black triangles may end up. So for example, on those lower incisors, as the teeth derotate, if there's been pressure between these teeth, then often the gums will have dropped. So we might want to consider doing IPR between these lower incisors later on if there's a black triangle. But because it's on the lower and it's nothing significant, I'm not too worried about it right now. You see that between the upper centrals, it also shows a little black triangle. Now again, in a case like this, I'm probably just going to wait and see if those black triangles actually show up. But you might want to be prepared to do some IPR for that third reason, which is the black triangles. Now, the next consideration for me would be, are we doing IPR? Well, no. If we were doing IPR, are we doing it when the contacts are derotated and easily accessible? So essentially when the teeth are straight. Right? I don't like doing IPR on super crooked teeth. I'd rather do it all at once when the contacts are open and accessible. But we're not doing IPR, so it doesn't make a difference. The next thing would be, are any attachments showing up partway through our treatment? So we can click on this tab here, our staging tab, and this shows these little triangles. What the triangles show you is when the attachments are placed. So there's no red triangle showing up in the middle of this staging pattern. So what that means then is we're okay. No attachments are showing up in the middle of treatment, or we're going to have to schedule a strange appointment to put an attachment on for whatever reason. It's all happening at the very beginning. Okay, and the next consideration is the number of trays appropriate? And yes, I think that in a case like this where we have a significant amount of sequential distalization happening, it's going to take time. What we'll talk about shortly is our lingual attachments, and because we have attachments on the lingua of those upper anteriors. So this patient, his protocol is actually a little bit different. He is actually going to be eating with his aligners in and changing out his trays twice a week. So essentially his instructions are, eat with your aligners in. As soon as you're finished eating, you have to take out your aligners, brush your teeth, brush your trays, and then pop them back in again. The reason why is because if food's getting stuck between your teeth, it's going to cause cavities. So you must brush your teeth immediately if you're choosing to do it this way. The benefit though is nobody's going to see the attachments on your front teeth. And whenever you bite down and hit those little attachments, because the trays are protecting it, it's actually going to push the tray onto your teeth more, and the movements will happen more quickly and more consistently. So if he's changing out essentially every 3 days with his trays, that means that he's going to be finishing 70 trays would actually be 7 months. So it's actually not a tremendously long treatment time frame right now. So I'm okay with 7 months of trays to start off with. Next, we're going to be talking about, well, is there going to be pontics or eruption compensation? Well, we are missing some teeth here. Now, in this situation, again, this is not accurate. We are going to be opening up space. So are any pontics, we can check by clicking the pontic button. Are any pontics showing up? Well, no. Yes, here's the question is, do we want to have pontics showing up? Maybe. We're going to come back to this in just a moment. So the main question, though, to ask yourself is, do you want to have a pontic? Say it's the central incisor. Do you want to have a fake tooth there? Well, yeah, I'm going to say probably you are going to want to have a pontic on central incisor. So this is just your check to make sure you're not missing that. Next one here would be ensure all locations, okay, we got that right. Ensure all locations needing pontics have them. Ensure upper eruption compensation is the right size. And the next one here is going to be pontics. Is it the right size and is it growing properly? You're going to see something a little unique in his case. We'll come back to that in a bit. Next, let's just jump ahead and look at the attachments. So if we are intruding teeth, we need to have the right attachments. If we're working on root tip, we need the right attachments. Right? We need to make sure that we have things set up properly. So the first section here I'm looking at is retention. So retention to start with, do we have retention to help correct a deep bite? Well, what attachments do we want to have when we're trying to correct a deep bite? The attachments that we want to have are on the lower uh, premolars and first molars. We want to ensure, especially on these lower premolars, that we have a good, robust attachment that's going to lock in. Because what's essentially going to happen here is the tray is going to try and lift up. And so the attachment that we need to have needs to be able to lock in on the gingival aspect. So this is the area of the attachment that's getting most used right now. Right? The tray is trying to lift off, while at the same time it's pushing down on our anterior teeth as it's trying to intrude them. So the tray is trying to lift off of these premolar teeth. So this is great. The attachments we have on these lower premolars is awesome. But the attachments that we have on this other side are horrible. Now, the reason why that is because the area where the attachment is engaging is actually an optimized rotation attachment on these two teeth. Well, the tray is just going to slip off these teeth. You're going to start to see this with the tray. It's going to slip off because it's not locking on as it's trying to intrude these anterior teeth. So it's actually going to fit perfectly on the anteriors. It's going to fit really nice. It's going to look great. And then the patient will say, well, the tray's trying to bounce on me. So, well, why is it trying to bounce? Well, it's trying to bounce because it's lifting off these back teeth because they don't have a nice horizontal attachment with retention on the gingival surface. So the change that we need to make is we need a change to put on either optimized deep bite attachments or, this is ClinCheck number 2, so you'll see what change I made, some horizontal attachments that again have a nice ledge where it's going to lock in on the gingival aspect of these premolars. So that's the change that we need to make. Now, let me just go ahead and modify treatment plan number 18, which is at the end of treatment, just so you can see how do you place those attachments? How would you make that change yourself? Well, you would just click on that attachment and then you can drag it over to the trash can right here, or you could click it and backslash. Let me just show you actually. So I can just click on this, right click it, remove attachment, or just highlight it, hit backspace on your keyboard, or grab it, drag it, drop it in the trash. To place other attachments, you click and you drag, you click and you drag, you grab the attachment, pull it out to its max thickness, especially for retention. And if you want to make it bigger, you right click it, you go 4 millimeters, you call it a day. Easy stuff. Okay, that's it. That's all we're doing here at this point. So you change out those attachments. Right, so that was our deep bite attachments. Next would be expansion attachments. So if we are expanding teeth, you always need an attachment on a tooth when it is expanding. If you do not put an attachment on that tooth, the crown will move, but the root won't move. And if that root doesn't move, the crown, when it moves, it's going to leave you with a hanging palatal cusp. So you really want to make sure that you have the right attachments on these teeth. Now, again, we're actually getting this patient to get his wisdom teeth out, so we can forget about the wisdom teeth. But the attachments that we want to place on our molars for the upper is a horizontal 3 to 4 millimeter attachment. I mean, this is unfair because you guys are seeing the final results because this was the last ClinCheck right here. So you essentially see that we fixed the crossbite, expanded the arches, fixed the deep bite. But essentially, these are the attachments that you'd want to place, 3 to 4 millimeters, pulled out to max thickness. Max thickness. That's it. Like you could understand the principles of the why, or you can just literally understand that the attachments you need for deep bite is lower premolars, 3 to 4 millimeters, pulled out to its max thickness. The attachments you need to help support expansion, conventional horizontal attachment or the optimized expansion attachment, 3 to 4 millimeters, pulled out to its maximum thickness. Like this is not rocket science. It's actually very straightforward. And my camera will go back and focus. There we go. So it's not rocket science, guys. Like this is pretty straightforward stuff that you can understand the biomechanics and the physics of it, the physiology of it, but you could also just recognize the fact that having that attachment is what you need. But let me explain a little bit of the why for those who are curious right now. So the why is, let's go ahead and give ourselves a root first. So here's our root. I'll only show two of them since we're in cross-sectional view. Okay, we need our root to move to the buccal. How do we do that? Where do we push down with 2 fingers right now to move the root to the buccal? Well, where we would push down is 2 locations. Whenever you're moving a root on a tooth, you would have to think about pushing with your finger in 2 spots, right? And I always want you to think about that, right? I want you to think if you were pushing, because aligners are just a force system. So if you're pushing somewhere, where do you push to make that movement happen? And the location of where you would push right now is you'd push down on this attachment right here, and you'd push up on this palatal cusp. And right now, some people might be saying, I have no idea why that is. I don't understand this. And that's okay. It doesn't matter too much that you, at this exact moment, fully understand it, but you're pushing down right here on this gingival aspect of that attachment, and then you'd be pushing up on the palatal cusp. Right? That's where the forces are occurring. That's why we need a horizontal attachment that has a nice crisp surface. So as you again push down on that surface and you push up on the palatal cusp, what happens is you create a moment, right? You're creating 2 forces that create a moment, and that moment is the root moves to the buccal. Well, why is that? Again, the simplest way of just drawing this is to, right between those 2 forces that are being put on the teeth, you draw the center of resistance, and then just continue on your arrow and curve it around that center of rotation, I should say. So just follow these arrows in the same exact direction they have been going. And this is coming out towards the, if we carry that red arrow over, that's the same direction as this blue arrow of moving the root buccally. Now, when I show this concept with a, I don't know, a G4 root control attachment for a mesial or distal movement, that is a lot easier to visualize than when we're talking about the buccal root movement. But I'll be showing you one in just a moment that's actually dealing with the second molar of a different tooth for root tip. So you'll see that in just a moment. And again, hopefully it will make sense. But if it doesn't, the key takeaway to understand is just the fact that you're placing a 3 to 4 millimeter horizontal attachment, holdouts to a maximum thickness, and that helps support the expansion of those teeth. Okay, so that was expansion. Back to our notes. Next will be upper incisors. So my upper lateral incisors, I always want to have an attachment on those teeth if they're moving. Let's go back to the proper plan. So are we moving our lateral incisors? Yes. Do they need attachments on them? Yes. Do lateral incisors pretty much always need attachments on them? Yes. So the main takeaway here is just that you need to have attachments on your upper lateral incisors. In this case, they're on the lingual. I'm going to be sticking to a pretty straightforward protocol here. I believe I don't change anything significant. Okay, the only thing I changed in this plan with my incisors is I took off the attachments from my lateral incisors and I placed vertical attachments on my canines. So my centrals lost the attachments, the canines went vertical. If I was doing this plan again, I would not take off the attachments from my centrals. You could probably just leave this exact attachment setup and everything would work completely fine. You're going to notice later on in treatment that I actually end up having some issues because I don't have any control over those central incisors by not having attachments on them. So again, if I did this again, I would actually leave attachments on all my incisor teeth so I could control the vertical aspect of those teeth. So I do change out things, which causes problems, but the main thing is do not remove the attachments from your lateral incisors. Okay, what's next? Root rotations and difficult movements. So what difficult movements are happening on teeth that we need to be aware of? Well, we've got a couple. And on this one, again, we have to remember that our lower first molars, second molars, sorry, are actually going to be uprighting. So in order to help facilitate the uprighting here, I'm placing an attachment on this tooth. Right? I'm trying to lock the plastic in so there's something to push against. And so you see the tooth uprighting. Now, one of the issues is that it's showing only the uprighting of the tooth to 7.5 millimeters, which is about the size of a premolar tooth. But in reality, this tooth, as it pushes back, we could actually create enough room for the molar. Because you can't see the root in this plan, but as this crown is uprighting, the root is still actually swinging mesially. Right? What's the easiest movement to do in a circumstance like this is this. Right? Here's our root right now. The easiest movement is just to move this crown back, upright the crown, leave the root essentially in the same spot. Not the most beautiful crown in the world, but literally just upright. So push against that crown. Just upright that tooth. Here, let's use a different color. Right, just push it up till it gets to this point here. The root doesn't have to move. Crowns moving through air happens really, really easily. So what you will find out is that this plan is destined to succeed. I could have not placed this attachment in the same way. I could have done something differently here. As long as that tray has retention, we probably would succeed. I used to do this case completely differently than what you're going to see here, where I pretty much did no attachments and didn't do anything special other than just having like maybe a retentive attachment, and it still worked. But if we want to have the best attachment on this tooth, it is to have a vertical attachment, and it would actually be to change the bevel on this attachment. So if the bevel on this attachment, and let me go back to this plan here. Again, such a spoiler because you can see that tooth uprighted. But if you place an attachment on this tooth, like we did before, now this one's further back, but it could be mesial too. If you take this attachment, let's first make it 4 millimeters, and we bevel this attachment towards the mesial, well, now we have this nice flat pushing surface available. Right? All of this pushing surface right here can be used to push the crown distally. Right? I want you to think again. Where would you push with your finger? So you have to push somewhere. Where would you push? Well, you push right here on the mesial aspect of that tooth, but you also push on this mesial aspect of the attachment. That makes sense. You could also go ahead, like we just said here, and leave it pulled out to its maximum thickness, just like this. And where would you be pushing here? Well, you'd be pushing right on the side of the attachment, right here. Right, to push that tooth distally. So that's also an option. The main takeaway I want you to get it again is just that it doesn't have to be perfect. When we start doing this plan with this patient, we explain to him that this is a complicated case. You have a crossbite, trying to work on your class 2. We have teeth that are tipped into the space. I never even talked about it, but that upper first molar has extruded slightly into the extraction spaces. And then the last thing that you're going to see here in just a second, let's just look at it right now, is this tooth right here, the 127, needs to have quite a bit of distal root tip put into it. The root has to move distally, and the distal aspect of this tooth needs to extrude quite a bit. And so this is the equivalent of a par 5 in golf. Like, this is not an easy case. This is going to take us 2 years. If you want us to treat you comprehensively and to fix your bite and give you the best situation possible, you need to understand moving teeth through bone takes time. Now, a lot of lecturers might say, well, patients can only handle 6 months of treatment. Or I've heard another one say a year, max, never more than a year. The reality is there's lots of patients out there who want to fix their teeth properly, as ideally, I shouldn't say properly, but as ideally as possible. And they're willing to put in the time and the work required to do that. I would say the average case we have is probably a year and a half, and not a lot of patients have issues with that. We have lots of cases that go 2 years and 2.5 years and even 3 years, if the complexity of the case requires it. Now, it doesn't mean that patients always make it through their treatment and they're always compliant or that they always love me. And it doesn't mean that I don't treat things sometimes with limited treatment and I don't fix all the problems. But I just don't want you to get into that mindset of it's not physically possible. It can be possible. It just depends on how compliant is the patient. Okay. So working through our checklist, we were currently on difficult movements, right? What are difficult movements that are required right now? So we've talked about the deep bite, we talked about the laterals, we talked about the expansion. Now we're needing to look at the second molar. Well, the second molar right now is distalizing, but really the position of it is that the root should be moving more to the distal. And it's so hard for me to draw this right now or to explain it without just showing it to you. So I'm just going to show it to you. This is actually the attachment that I place on this tooth. I've placed 2 3mm attachments. Now to do that, I had to ask the technician. I couldn't place this myself. You cannot drag on 2 attachments at the same time unless you get really tricky, but you can drop 1. We could have just gone with a 5mm. If you want to place the second one, we'll see if this behaves right now, but you can sometimes drop it on the lingual and then you actually go ahead and grab it and drag it. And it sometimes takes a lot of clicking and dragging and clicking and dragging and clicking and dragging. And then I want you guys to have a break at some point tonight, seeing as we're already at 7. But eventually, ooh, it's getting close. You can kind of tell. If you finick around with it enough, you can get it to just kind of glitch out, and then it will put it over to the buccal side. But I'm not going to worry about that right now. Okay, so what I do, though, is I could have just gone ahead and placed 1 attachment, and I'll show you the orientation in just a moment as to why I place it like this. Right, 1 attachment that was 5mm. Or in this case here, I really wanted a 6mm attachment to have more space, but with us extruding, and this is what I changed in the movement, is I extruded the tooth and I create a lot of distal root tip here. So where's the surfaces that we're pushing against? Well, the first surface that we're pushing against, if we're going from here to where we're at the end, let me again just draw. So if this is where we're trying to get the tooth to end up at the end of treatment, right, we want this cusp to come down. Where do we have to push against to make that movement happen? Well, we need to push against right here. We need this surface to push and extrude. But think about this, right? If you actually just straight up pushed here and nowhere else, like you think about using your fingers, you literally just pushed. All that would happen is you would push the crown to end up like this, right? It would just tip the crown towards the distal. That's all it would do. So that's why anytime you move a root, you need a second area where it's going to be the counteracting force to create the moment. And that's where this comes in. Right? This is the area here, as well as actually on the tooth itself, on the occlusal table, that you're pushing against to create that counter moment, or the counter force to create the proper moment. Again, where would we, for the understanding component here, draw our center of rotation then is between those 2 points. Keep drawing these arrows. And this is the force that we're creating. And you'll see when we look to our next treatment plan, to treatment plan number 6, it worked. Right? From where we first start to where that tooth moves to, it works, and it works really well. Now, I will warn you, this is not always consistent. Extruding a terminal tooth while creating root tip can be a really challenging movement. So I don't want to give you rose-colored glasses and say, this is always going to happen perfectly. This patient has to be really compliant. And I think that's where eating with the aligners then always helps, because he's not going around for 4 hours each day with the aligners not on his teeth. So they have to be super compliant for a case like this. Okay. So we're looking at the difficult movements. We'd skipped over the pontic side, because we're going to address the pontics in a moment when you can see what we actually do. But let's just see again on our, oh, not resume modification. I need to see the instructions. So what other root movements are happening? Well, the lower first molar on both sides need to upright. We talked about the attachments, just placing vertical attachments being sufficient. The other thing you'll see when we actually look at the plan is that I'm going to be placing attachments as well on the lingual side. I'll show you that when we get to it in just a moment. The last thing here is the elastics. So because we are going to plan to do some sequential distalization, well, sequential distalization will only happen if you are using elastics. Anytime you are trying to back a tooth up, you must use elastic rubber bands. If you don't, that tooth won't actually move back. The ClinCheck could show it. And even when you check and the trays are fitting, it'll fit. And you'll say, look, there's a gap. It's backing up. It's working. But the reality is it's not. Because what's actually happening is that first molar moves back. And then the next tooth will start moving back. The first molar will move back. The second molar moves back. First molar moves back. Second premolar starts moving back. As that second premolar starts moving backwards, the back tooth is going to start getting dragged forwards. So you're not going to actually be distalizing the second premolar as much as what you think, because your second molar will actually slide forward. So in order to distalize teeth, you have to use elastics. Well, in this case, where are we using our elastics? Oh, wrong slide. Let's use the right view. There we go. So where we should be using our elastics in this situation then is we're using them from the lower first molars. And where we're going to be hooking them onto is to the lingual of these teeth. Because when you run an elastic from the buccal of a lower tooth to a lingual of the upper tooth, as it goes from that buccal to the lingual, it has a crossbite component. Now, ignore the fact right now on there that there's 2 lower cutouts. We're going to be removing the one. We're going to remove the one off of the first, I think. Maybe not. Maybe I actually left it for the crossbite component. But the main thing is that we're able to correct the crossbite while we're able to work on the class 2 situation if you run from the buccal of the lower to the lingual of the upper. So no, I did leave it. I left it on. So on the one side here, we run from the buccal of that lower 7 to the lingual of the upper 4. On this side here, we're running essentially, now I do show that I have a button on this 6, but I'm quite certain I did not use that, because the elastic situation that we want right now is to go from, oh, well, that's too small. Okay. So here's our button, and we have a button on the lingual of that tooth. Where we want to go, let's just do a dotted line to represent that this is on the lingual. Where our elastics will hook on is that they're going to hook on from the buccal of the lower 2 teeth, and then they're going to go to the lingual of the upper And so if you're looking at the net resultant force of where the trays are pulling, well, this tooth is going to be getting pulled towards the buccal. Right? It's coming out of the screen at us. And then we have the class 2 component. The crazy thing is, because I know a lot of you right now are thinking, the crazy thing right now is the fact that we currently are trying to distalize this tooth. Right? We're trying to distalize that second molar while we're using class 2 elastics. And you might say to me, well, Stephen, won't the class 2 elastics overpower the aligners? Here is the crazy thing. But if we have enough retention on these teeth, right, we're uprighting those teeth with those vertical attachments. Remember how we beveled them towards the mesial? And this is where I talked about, I'm going to add on just a horizontal attachment. Nothing special here, just something to lock the tray in place. All this is going to do then, as this locks in, is that's the only reason I'm using that is just for some retention, because the vertical attachment is not great for retention. And so we're going to then use our vertical attachment for uprighting the tooth. The horizontal attachment is for the, why am I struggling with words right now? Is for the retention aspect. And then the elastics are for crossbite correction and class 2 correction with some sequential distalization. Oh boy, there's a lot going on there. Cool. Okay. So again, every decision we've been making right now, if you break it down, it makes sense for each individual little puzzle of this Sudoku puzzle that we're solving. My dad really freaking loves Sudoku puzzles, so that's where my analogy comes from. Right? You solve for one little thing first, then you solve for the next thing. So it's like you need deep bite correction. Go ahead and intrude the lower incisors and canines a little bit more than what you expected. Remember we talked about before this canine was too far down. So all we did was move that tooth back up a little bit. So we need the right attachments, some nice horizontal attachments, help intrusion. You need to keep the laterals in the right spot, lingual attachments on the laterals, or buccal, whatever, doesn't matter. You need to upright these lower first molars, some vertical attachments. You need to go ahead and create distal root tip, a 5 to 6 millimeter angled sash attachment. You need expansion, horizontal attachments. You need to make all these movements happen. You need enough trays. That's why we're looking at like 70 trays. Okay, the last component here is the Pontic situation. So we talked earlier about how we want to push against these lower first molars to upright them. Well, what happens here is if we have no Pontic at all, it's actually not a terrible thing because when the plastic grips around this tooth, where it's going to grip is, let's draw this again. So the aligner is going to grip on the lingual. It's going to grip all on the buccal. But wherever there's a Pontic space, there's a bit of a bridge right now. Or not a Pontic space, sorry, but wherever wherever there's a missing tooth, if you have no Pontic, this is the area right here where the tray is not going to touch the tooth. But let's say you do have a Pontic now, right? You have a big Pontic. Well, the area that's not going to be touched by the tooth, I have a great slide showing this in the foundational systems course or the attachments and biomechanics course. I can't remember which one, but it's going to be a much bigger space here that's not being touched against by the plastic if you have a Pontic. Right, so here's our tooth in that space. So the areas for pushing have become more limited because you can push kind of right here and there, and you can push against the attachments. Sure. But there's less space than if we just had a little tiny ponticless area here, right? For those who understand what I'm saying, if you don't have a pontic, right, there's this little bridge that connects the teeth together, right? There's this bridge of plastic right here. And so it gives you better control, but sometimes it becomes very hard oh, and I lost my wrapper again. Sometimes it becomes very hard for the bridge of plastic for this tooth to lock in place. And so what we're going to do here is, I wonder if it's because I'm drawing on my slides. Let's go back there again. Yeah, I think maybe that's why it's doing it. So what we're going to do is we're going to ask them for a Pontic. We're going to say, please give me a Pontic. But I want the Pontic to be undersized. I want there to be 1 millimeter space between the tooth and where the Pontic starts so that we get a full wrap of plastic. And then please grow the Pontic, but never allow it to come in that 1 millimeter of space. So what this does is, as this Pontic grows in size, it keeps rigidity to the trays. It makes it easier for the patient to remove the trays because they can put their finger underneath this Pontic and pop it out. And same thing on the other side, right? The Pontic starts now. In this case, they put the Pontic a little bit too close. Should have told them not to start the Pontic right away. But then the 1 millimeter of space opens up, and then there's a Pontic that grows throughout treatment. But it, again, never touches, other than that very beginning, it never touches the tooth. So it keeps a full wrap of plastic around this tooth. So we have more control on pushing that tooth distally and uprighting it. So let's go ahead and take a look. Clinically speaking, after all of that, how did we do? So let's compare where we started here and where we're at after our first series. Look at the distalization that's happened for that lower first molar. It's great. Same thing for the lower first molar on the other side. Alignment for the most part of our lower incisors. Uppers are looking pretty good. The arch development and expansion looks awesome, especially this upper first premolar. Right, even though we took off the attachments off our upper central incisors, those moved without issue. Now we're still biting fairly class 2. Right, that tooth distalized, the anteriors slightly mesialized, but we're still quite class 2. On the left, or on the right, this side wasn't so class 2 at the beginning, and this one is close to class 1, so it's looking pretty good. The deep bite correction. And look at that canine, how much it has intruded. And same thing on the other canine. And even though we actually showed it intruding a lot more than what's in this real life situation, or in the ClinCheck, in real life, it's actually pretty flat now across the occlusion. So we're in a really good spot. His smile, obviously the camera we used before was not very good, but his smile looks great and it's filled his buccal corridors. So at this point here, I mean, we've done a significant amount of arch development. We've aligned the teeth. We've uprighted these molars. And again, the main takeaway I'd love for you guys to have is to recognize the fact that we have uprighted those molars. And even if that's all you were looking to do right now is just figure out, how do I upright these molars? Mission accomplished. Like, you don't need to know the arch development. You don't need to know the lateral incisors. You don't need to know the elastics component of it. All you need to know is the fact that you can upright lower molars that are tipped really, really easily just by placing a vertical attachment on them. If you want to have some extra retention to make sure they lock in really well, place a horizontal attachment, call it a day. That's all you need to do for that component. That being said, we're not quite done. We're not going to just call it a day because we still have more movements that we want to make happen. So let's go ahead and take a look. So what do we do on our next plan now? Well, on our next plan, we're still working on some class 2 correction, so some more distalization of those upper molars. We're growing this Pontic a slight amount because we want to make the space a bit bigger for these teeth. And we realize that our lateral incisors on our lowers, well, the root here is angling towards the mesial. So I place a vertical attachment to try to help work on the root position of those teeth, to move that root back slightly towards the distal. That's it. Because we've corrected our crossbite now, right, again, look how great that was. But because we've corrected our crossbite, For some reason, I'm really mean, and I decide here that I'm going to place a button on our upper canine too. So he's actually using, oh, you know what it is? I'm using a midline elastic. I'm using a midline. So I'm actually having him hook the elastic on from this upper canine at nighttime, just when he's at home and sleeping, from the upper first or upper right canine to the lower left canine. So he still has all the buttons if we need to use any class 2 correction on both sides. So it's the same exact setup as before, but I'm having him, to correct the midline slightly, use an elastic from the 1-3 to the 3-3. So it's dragging. Let me just draw this. Okay, so here's my button here and my button there. Okay, leave the elastic in blue. So it's going from here to here. So that's pulling my upper midline this away, pulling my lower line midline that away. The goal then is that these will meet in the middle. See, I thought that was my drawing that kept getting rid of my background, but it looks like it's still there. Anyways, so that's how we use a midline elastic. The size of that elastic, for those wondering, would be 5/16, 3.5 ounces. This isn't really an elastic specific lecture. I do cover that in other courses, how to use elastics and how to choose sizes and whatnot. But yes, 5/16, 3.5 ounces. Okay, so that's what we're working on with this plan. Nothing crazy. Again, why do I have as many aligners as I do? 60 aligners. Well, he's eating with his aligners in. And because the elastics component, that is what takes the most time. If you are trying to correct somebody to a class 1 molar occlusion in a non-growing adult through sequential distalization, it will take you, in a case like this, for sure 2 years. Like, it is going to take time. And so even at the end of this, I'm realistically not expecting to be there, because it doesn't matter that it moves the teeth faster eating with aligners in. It goes slower. Just using elastics is what's moving these teeth. It's not actually the aligners as much as it's the elastics. Okay, so this is where we get to, let's go back to his photos, after his next batch. So a little bit more arch development. Again, arches look great. His midlines, they're still not quite there. We're trying to make it better, but still not quite there. Refine the space a little bit more for the tooth. And so now we get to the point that we haven't made a ton of changes with the class 2 correction, even with another 6 months. So we're going to do things a little bit differently now. What we're going to do differently is we're actually going to do some sequential distalization while we do some sequential mesialization on the lower. So again, the elastics are a must. You must use the elastics. But what we're doing now is the same sequential distalization, but on the lower at the same time, we're sequentially mesializing a little bit. And we're leaving this space a bit bigger. To work on moving our midline over, again, some would say that this is unnecessary, but he wanted to try and get his midline as close to perfect as possible. We did do some IPR so that we can move those teeth over into the IPR space. Again, sequential distalization on the one side, sequential mesialization on the other side. Here's an example of what it looks like as we're partway through treatment. Right? So we're sequentially mesializing the lower canine, then the first premolar, second premolar. And on the upper, here's the space of the first molar. That's the second molar is distalized, then the first molar, then the second premolar, then the first premolar, then the canine. Now, again, I want you to understand that this doesn't always perfectly happen that way. There are definitely cases of sequential distalization where patients do not wear their elastics well enough, and they do not end up in this position here of perfect class 1. But it does take time. It absolutely takes time. So this is where he's at the end of this batch, which is what you just saw in the actual clinical photos. But even with everything we've been doing, his root tip on these teeth is still just not quite right. So we're doing one last batch of aligners just to work on some tip So we're just working on the tip on the lowers, a little bit more arch development and expansion just to settle the bite. I'm not worried that he's biting slightly open because he's hitting on these lingual attachments. Right? These lingual attachments that are there, they will prop the bite open. Now remember before I talked about how we did not have an attachment on that upper first molar. And let me go back to the photos and show you. Right? We started off, well, let's go all the way back. We started back here. Centrals are even. Then to here, centrals are still even. To there, centrals are even. Eventually, though, at this point here, you can see that as we're tightening the contact between the central and the lateral, it pushes our other central incisor, and it actually caused some unwanted intrusion. Right? So check this out. As this central tightened up the contact a bit more than we wanted, and this lateral tightened the contact a bit more, because there's no attachment on that central incisor, well, the plastic is covering that tooth. It's covering like right here. Oh, let's not do an arrow. Let's undo that one. Let's do some drawing. So the tooth is touching here and here. And then on the incisal is the tray. On the buccal is the tray. And on the lingual is tray. So there's tray covering this tooth in every direction except one, apically. Right? This tooth only has one direction of where it can go. It can intrude. And so as these two teeth, again, were tightening some contacts without an attachment, and I wasn't paying attention to how much it was tightening, it intruded that tooth. So now the edges of our teeth are uneven. And so what we need to do to fix that now is we need to do some extrusion. Now, am I worried that we've accidentally intruded this tooth slightly? No, not even slightly, because we know that we can extrude that tooth pretty easily. All we're going to do is we're going to put an attachment on the lingual aspect of this tooth, a horizontal attachment. You could also place something on the buccal. And we're just going to extrude it back, just like a controlled relapse. That's it. Easy peasy. Just put the tooth back in the spot, put an attachment on it, on the buccal, on the lingual, it doesn't really matter. And that tooth will extrude back down into occlusion. And this is where it was after we finished that intrusion. All right, let's look at it clinically. So it was here, and that's at the next batch. Okay, we did a little bit of bite settling at the very end here. This was batch number 5. We told them it was a par 5. It did end up taking 5. And from here to here, oh, actually, never mind. That's actually the modification I'm making on it right now. Let's go. It was here. So no attachments on the teeth. Just a little bit of bite settling. Well, he gets some restorative done on his teeth. We asked for 15 aligners, no attachments. We just want to settle the bite, anything that's not in full occlusion. Some fake IPR here just to tighten the contact between the canine and the lateral. We don't want to do too much because that's what caused that central to intrude, which again, not a big deal. Just a little bit of bite settling, and that's where we're at. So to finish up his case, midlines got very close, but we actually did not quite get them perfectly on, even despite all of our best efforts. But he's got the right amount of space for implants now. He's set up, we've arch developed. Treatment time was just over 2 years in total. And it obviously shows us what is possible. So again, I know I hit you with a lot of content there. It's okay that you might not feel comfortable and you might say like, wow, Stephen, that went over my head. I know some of you will take a lot of pearls from this. Others of you might just take one pearl. But my goal is I don't want to dumb down to you guys. Clearly Select, which is our growth program. Now, Clearly Select has 5 goals to it. Our goal of Clearly Select is that you can jump on a webinar and you can hear me talk for 2 hours, but it doesn't mean that you're going to improve your skills. We want to fill in the gaps of what's missing for you. We know that there's a component that you need to have, which is knowledge. You need to get the information so you can actually do this. But the second thing you need is confidence. And where that comes in is working with us to have ClinCheck designs created for you. So all doctors who join Clearly Select will have 10 ClinCheck plans that are created by our team. Kelly is intimately involved in this and is fantastic at what she does, but helping design plans that keep you in the guardrails, but also help you push your comfort zone to do things that otherwise you wouldn't feel comfortable doing without our support. So the goal is no matter what, if you're joining Clearly Select, you will take on 10 cases that we will help plan and design to the level of quality and detail that you just saw in these 2 cases. We'll do that for 10 of your cases. The third component is that you'll be able to join our community with our conversations in our Slack chats. Slack is like WhatsApp, but not so intrusive into your life. So you will be part of a community that has questions answered about your cases, about your clinical circumstances, or just people to support you in whatever it is that you're doing in orthodontics or in dentistry. You receive support with operations with all the different systems that we use in my practice as a Diamond Plus provider, but you'll also receive a significant discount that will save you tens of thousands of dollars per year because we can guarantee that the discount you receive is going to be bigger than the discount if you're not in a DSO right now, that a discount that a solo practitioner would receive. The last
Awesome.
thing, which I think is so important, is accountability. Right? I'm pretty hard with my patients, like I'm a strict dentist. I'm also pretty strict with the doctors that are in our Clearly Select group. I want to know what your goals are and what you're trying to accomplish. And then we're going to work to try and help make that a reality. But our goal is we can only lead a horse to water. You can't make it drink. And so that's where we help provide accountability for doctors. Because the goal of Clearly Select is we want to be the Rolex of education. We aren't looking for just anybody. We actually reject half the people who apply to be in Clearly Select. Our goal is to create a top notch group that provides all of these different resources so that you grow, you do better, and you're able to have the lifestyle that you want with working less, using your brain and doing fun things, and making a lot more money, to be honest. So that's essentially the conversation for you is we almost guarantee that you will always come out ahead if you join Clearly Select and you're willing to put in the work. So if it's something you're interested in, there's a link right now in the webinar chat. It's essentially our Clearly Line website, and then there's a link to join Clearly Select, so you can check it out there.